Good afternoon and welcome. My name is Nick Davies and I'm a Programme Director here at the Institute for Government. On behalf of the Institute and Novartis, thank you very much for joining us for this second in a three-part series of events looking at implementation of the 10-year health plan, with today's event looking at technology and innovation. Better use of technology from the transition from analogue to digital, greater innovation are at the heart of the 10-year health plan. That includes plans to make the NHS app a gateway for the entire NHS, to integrate AI into clinical pathways, create a new health data research service, make genomic sequencing of birth universal, utilise wearable technologies in treatments as standards, and to improve the take-up and adoption of medicines. Technology and digital transformation are also central to meeting the challenging efficiency targets that DHSC has signed up to as part of the spending review. So what are the potential benefits and risks of greater use of technology and innovation in the NHS? How deliverable is the 10-year health plan vision for the use of both? What are the barriers to greater adoption, and how can investment in technology and innovation be protected and prioritised? To discuss all those very big questions and more, I'm delighted to be joined by Dr. Sam Roberts, Chief Executive of the National Institute for Health and Clinical Excellence, Matthew Chizambi, Director of Imperial College Health Partners, and Johan Kallström, President and Managing Director, UK and Ireland at Novartis Pharmaceuticals UK. Each of our speakers is going to make opening remarks. I'll then ask a couple of questions to them before opening it up to questions from the audience. If you're watching online, then you can start submitting your questions now, and we'll try to get through as many of those as possible. Right, without further ado, I'm going to hand over to Sam Roberts.
Great, so thank you so much for coming along or joining online. In some ways, politics moves so fast right now, we have to dial our mind back to what was happening in July when this was published. So I'm going to talk a little bit about that and not really dive into kind of the main hot topic in the press at the moment, which is medicines pricing, because that really didn't feature much in the 10-year plan. So in the 10-year plan, there were a couple of things from NICE's perspective that we really wanted to land, and we're pretty pleased that we did. And they were faster, fairer rollout of health tech, smarter spending through dynamic assessment, and more rapid assessment of medicines. I'll talk through each of them kind of in turn. Faster, fairer rollout of health tech, where there's lots of devices, diagnostics, digital products that don't have as fair a go of it in the NHS as a medicine would. So there isn't any national price negotiation, there's not any national contracting or procurement, and when NICE says yes to a medicine, there's a statutory responsibility for a commissioner to buy it. When NICE says yes to a digital technology, everybody can pretty much ignore them. So we were really delighted that in the 10-year plan that disparity has been addressed. And so NICE advice on a small number of health technologies that are addressing the most important NHS needs will have the same kind of funding mandate, we call it, as medicines. So that was the first thing. And these are kind of the kinds of things we're talking about. I was going to give you broad brushes on things like the artificial pancreas that keeps children out of hospital by managing their glucose. It's AI for skin lesions to make sure people don't need to go to hospital for assessment, etc. So that's the first. I'll be quick on the other two. The second was smarter spending by continuing to look at innovation. And the way we describe this at NICE is we've been really good. We're like a grocer that keeps on putting new things on the shelf. Oh, new innovation, new innovation, new innovation. So 25 years, it's a very busy shelf. And so now we've been given the powers to do a bit of a shelf sort out. And so the shelf sort out can have lots of parts to it. It can be bringing some innovations closer to the front of the shelf. So you may see that we've done that with our chronic heart failure or our type 2 diabetes guideline, the latter of which could impact 22,000 people by using a type of medicine much sooner. Some things are kind of ordering the shelf, and some things are just taking innovations off the shelf. They're not really as useful anymore. So an example of that is a recent prostate cancer medicine where we saw that you could both benefit 4,000 people and save the NHS money by using a biosimilar. So that's the sorting on the shelf. And then the last one is pretty simple, which was speeding up our review of medicines by 3 to 6 months by working in lockstep with the MHRA, which is the licensing body. So our aim is to make it much quicker between when a medicine gets a license and NICE says yes, and we're doing that by closer working together. So that's the summary. Faster, fairer rollout of health tech, smarter spending by sorting out the shelf, and then getting access to medicine sooner.
Thank you very much. Matthew.
Great, so I'm going to go a little bit further back than July. So in 2004, Derek Wanless outlined a case which is still stuck within the 10-year health plan, that the NHS will not be sustainable unless we focus on prevention and keeping people healthier for longer. But in 2025, we still don't have that preventative system. So therefore, I think it's really incumbent on all of us to think about what is different this time. So in that same kind of time frame in 2004, 7 people got together to create a company which was then called the Facebook. And that has now fundamentally shifted lots of our lives. So there is, for us at the Health Innovation Networks, there's this fundamental belief that the technology and the innovation that happens in our daily lives needs to be brought to health. So whilst health is our priority, we do believe that there are key economic benefits of having a greater focus of the innovation, and this is why we welcome the 10-year health plan. First is around NHS productivity. As taxpayers, we've really got to think about how the NHS demonstrates value for the significant inputs that it gets. Then second is around workforce productivity. Healthier people are able to be part of the employment, and therefore they are also able to live more meaningful, longer lives. And it's really, really important for that in terms of wider determinants of health. And then the third, which is also important as we think about what we can all contribute to the UK economy, is around economic growth and how we can create a life sciences industry that can really thrive. So when we think about how we can do things differently and what's enable that future, it's really important that we focus on an aligned system where we have different bits of the ecosystem that are working together towards the aims of the 10-year health plan. And whilst capital funding and different barriers do exist, I think one thing which is less talked about is culture. It's very important that NHS colleagues, and there are lots who do amazing work, really think about how we can view innovation and working with private industry not as a negative, but really a positive for how we can create access to innovations. And a great example of this is weight loss drugs, where we have the people who need it the most are unable to pay out of pocket. The people who also need it the most, currently we have a system that engineers towards you being sick already. You've got to have multiple conditions and so on and so forth. So I really think it's about how we start to engineer a system that optimizes towards the 3 shifts. At the moment, we're not quite there yet.
Thank you. And Johan.
Thank you very much. So I'll lean into the perspective of how adoption of technology and innovation really becomes a prerequisite, I think, for delivering the NHS 10-year plan. And I represent Novartis here in the UK, and we are proud to be one of the leading life science companies here in terms of driving innovation, in terms of driving access to medicines, but also a company that has a really strong track record of building partnerships with NHS to deliver better outcomes for patients. And I do want to make the point that when we talk about innovation and technology in the context of healthcare, the mind quickly goes to AI, to data platforms, to digital tools, but I don't want to miss the opportunity to point out the fact that we don't often talk about medicines in that same breath. And I think that's something I want to reinforce, because medicines are actually one of the most powerful technologies or innovations that we have already available at our hands. Something that we know saves lives, it can transform lives, and I think importantly, to build on points raised previously, they really underpin a more healthier and a more productive society, which I think is something we urgently need to solve for. Also, I want to make the point that the innovation in medicines doesn't happen in a vacuum, and it requires a system that stands ready to both co-develop, but ultimately also adopt and scale new treatments. And it needs to happen quickly, in an equitable way, to your point as well, and also sustainably, because I think that's the other element. We need to find solutions that will actually make sure that we reach the right patients at the right point in time with the right drug. And for me, also, it's important to underscore that it's not just a health outcome that we're talking about. It's really an economic one. And the link between health and productivity, I think, is clear. And we know that adoption of medicines pays dividends, both in economic and in human terms. And the work that you do at NICE has clearly articulated that. Now, if we look at the NHS 10-year plan and the ambition that's set out, I think we are very much aligned to that as a life science company, but we also acknowledge that we think that a prerequisite for us to deliver on that or to realize it is an earlier and more effective use of medicines. And I think we talked about, obesity, cardiovascular diseases, another area where we know that using high efficacy treatments to lower LDL early on in disease can really have, a profound impact on stroke and myocardial infarction, and that in itself will lean directly into the government's goal of reducing cardiovascular mortality by 25%. We have a number of examples in cancer where we know that access to precision medicine for the right patient at the right point in time, again, can dramatically improve survival. And these are just a few examples of how medicines, when we use them proactively and supported also by the right technology and diagnostics to make sure that we identify the patient who will really benefit from the treatment, that can prevent disease progression, it can improve outcomes, and ultimately help deliver the NHS 10-year ambition.
Thank you very much. I'd like to ask a few questions about creating a culture of innovation both within the public sector and then also how the public sector creates that in the private sector through its relationships. I think I might come to you first. We often hear that the government is quite risk averse. The civil service, wider public sector is quite risk averse, and often for very good reasons. You're delivering hugely important life-dependent services and you don't want to mess around. But given that, how can government or the ministers or senior officials, how can they help to create a more innovative culture within the kind of different bodies of the NHS?
So, because you mentioned risk, I'll probably pick up some process points, but also the cultural bit. So there was a lot of consternation about the 10-year plan in terms of how it would be delivered. But I think that actually the medium-term planning framework, even the fact that it's a medium-term planning framework over 3 years rather than in-year risk, actually allows and helps create that cultural moment for leaders to go, I'm not planning for balancing my position by the end of the year. I can actually think about a 3-year kind of thing. So that process point, I think, is so important to start to create the leadership headspace to think about how we can actually think about risk. Because when we look to pharmaceutical colleagues, the risk time horizons are far longer. You're going through phase 1, phase 3 trials, huge amounts of risk within there. And it's only through enabling our public sector leaders to be able to trust them to actually think about year-on-year risk that I think we can start to unlock some of the cultural enablers for people then to start thinking about what's the right thing to do rather than the thing I have to get done by March 31st.
And Sal, I'd like your perspective on effectively, how can government be a good customer? That often it is trying to kind of buy in innovation or kind of technology change from the private sector where there's kind of greater expertise in some of those fields. How can the government ensure, I guess, one, that it has the kind of right capacity internally to know what it is buying, and two, how can it create the conditions that companies want to go out and develop those tools, medicines, products?
Yeah. So I'm not a procurement expert, so I'm not going to talk about that.
Sorry, I always want to talk about procurement.
Don't we all? Exactly. But maybe I can say two kind of areas where we at NICE see that there's opportunity for traction. So one is so your great example of, we've got a bunch of medicines that have been approved that are not being used. So cholesterol is a great example. 50% of people at high cardiovascular risk are not taking a medicine that is as cheap as chips, a statin. But what we ended up finding is that just making the medicine available, doing NICE guidance, doesn't mean anybody actually acts on it. The diffusion of innovation is a very, very slow process. You can't rely on passive diffusion. So if you look at what happened last year, we updated, there was a new crop of medicines were approved. We updated NICE guidelines. The NHS did a target, put a GP incentive on it, and hey presto, in a year, 700,000 more people got cholesterol-lowering medicines. So I think that's kind of thing one, is with adoption of big public health priorities, and I agree with some of the ones you mentioned, you've got to follow it all the way through. You can't just say, oh, NICE has said yes and sort of leave it. So I think that's the one thing of prioritising and kind of following it all the way down to the prescriber. I think the second thing is being clear when our methods don't work. So I'll give an example of where we were on digital and AI about 3 years ago. We looked at it occasionally and we just always ended up saying, no, not enough evidence, not enough evidence. Well, I mean, that is obviously not being a good customer because you need to help people get the evidence. So about 3 years ago, we introduced this new program called Early Value Assessment. And rather than saying you need the perfect evidence, we said, we're going to say yes if you've got good enough evidence to be used in the NHS, and then we're going to be really specific to you about the evidence you need to collect, where you can get the evidence from, the kind of study you should do. We're going to try to link you up with some funding through NIHR and other sources. And so far, we've looked at over 100 different innovations with that. 70% are collecting good data. So NHS patients are benefiting. We're getting the data from a very good health system that collects data very well, and we know it can come back to NICE. So I think it's both at the beginning of the pathway, helping people get through, and once NICE says yes, actually following it all the way down to the implementer.
Yeah, I'd like to kind of ask you a similar question, but from the other side. Like, what are you as a company looking at in terms of various national governments you might be working with and deciding what you want to invest in? Who's going to be a good customer for those potential products?
Yeah, absolutely. I think it starts with, assessing and understanding, is the environment that we're operating in conducive of, adopting innovation, and is there willingness, to your point, all the way through the system from a decision of what's value to the system until it gets to implementation. I think also aligning the incentive towards actually adopting innovation and moving away from the short-term frame of thinking it is a cost into looking at what is the longer-term value. And I think for us, for example, those decisions start early on when we think about where do we go with our research, for example. And if we see that there is opportunity to bring clinical or medicines innovations into a system, that's the right starting point for us. Then we want to go here with clinical trials as well. If we see that's going to be a complicating factor, I promised I won't talk about prices. I'm not going to talk about clawback taxes. But I think for me, fundamentally, if the system is wired and committed to adopting innovation, that's the most important starting point. Because when we see that we have challenges on pricings, we have challenges on clawback taxes, and we, on top of that, have very slow adoption, then it becomes a very complicated equation for us to say that that's an attractive environment to invest in.
I want to pick up on that adoption, diffusion point that you've both touched on, and picking up on your point on productivity. Clearly, the funding for this year was increased a relatively substantial amount. Spending is much tighter for the rest of this Parliament. The NHS really needs to hit its productivity targets to avoid having to make some really, really difficult decisions. If you're in an NHS trust and you're working out, should I be aiming for this new AI technology or new medicines versus should I be trying to kind of implement lower tech, proven technologies now in order to hit my budget for the next few years, what would you be recommending? Where should the focus be?
So I think that's a very broad question. I would say that the bit here is, I'd reframe it as which bits of the system need to help frontline providers make those decisions, right? Mm-hmm. So I think at the national level, clearly NICE, and we are so privileged to have an organisation like NICE within our country that in effect is a custodian of taxpayers' value. So I do think but one of the things which does need to kind of evolve within NICE framework is this concept of what the value is. So clearly economic growth is a priority for the country, and therefore how do we start to include that within value assessments? Then I think at the middle layer, the kind of system level, there is something about how do we translate those national outputs of what is valuable to then help support individual provider organisations about, for your particular context and your particular health needs, this is what we think you should be doing. And this is where it's so important that we do enable strategic commissioners to really do their job effectively. And there are lots of kind of challenges in terms of the redundancies at the moment, but enabling those bits of the system to really grip their jobs, which is creating a payer function, making allocative decisions about this is where you should invest, this is where you shouldn't invest. I think that is such a critical part of our system, which we've not had before, and places like the US have by design through insurance mechanisms.
Mm-hmm. Put that question to you as well. You gave the example of something that you have kind of seen scaled up, take up.
Yeah.
I guess what are the kind of broader lessons that you would take from that example that could be applied more widely?
Yeah, so I suppose there's two different questions. I'm going to answer the one that I want to.
Please.
Sorry. So the truth about making the health budget balance is that the kind of innovations we look at, which are diagnostics devices, digital, and medicines, are on average cost incurring. And there is no magical formula or changing the value framework or whatever that would change that for the NHS. So I think, and I don't say that lightly, right? I've been in this role for 4 years. Every Tuesday we look at the health economics of every piece of guidance that we put out. So that in those 4 years will be over 500 pieces of guidance. Very few of those are cost saving. I'd say less than 20%. I don't have the exact numbers. So then what does that mean for a government that's trying to balance their books? Mm-hmm. I think it means a big thing and a small thing. So the big thing is you have to believe that the savings are coming from somewhere else, right? So would that be big productivity enhancing tech? We don't look at things like e-rostering or scheduling or EHRs or FTPs or any of those things, right? But who is looking at that? That's not really clear to me. So I think that there's a big piece of work to do on productivity enhancing tech. And then the second big piece of work to do is what are the clinical priorities? So we're pretty excited about the National Quality Board, which will have these kind of like casting back to the old days, remember, James, of the national service frameworks. They're now called modern service frameworks, where you're saying this is the absolute minimum that must be commissioned everywhere. So that will help drive priorities, which I think is kind of your question about adoption. And then there's a small thing that we can do at NICE. I've talked a little bit about tidying up the shelf. There's some more stuff that we do where we are looking a lot at biosimilars, which is where something works the same as a branded medicine but can be cheaper. And we're also looking at health tech that's currently in use and seeing whether the price is justified by the outcomes. But to give a sense of the quantum of those savings in no way offsets the cost incurred by innovation. And I'm not saying cost incurred in a bad way, by the way. Innovation is for to deliver health gain. All of these innovations deliver health gain. They just don't deliver cost savings, which I think was your point.
Yes. So yeah, if some of these things are going to cost more, what is the case for spending more?
I think it's an interesting element. First of all, to your point, Sam, in terms of cost saving, I think when you look at the value of innovation, take medicines for an example, if used right, the value of a medication extends far beyond the healthcare system,
Yeah,
and which of course is the lens that you will evaluate it through. But if we talk about kind of the broader agenda that the country is on in terms of driving productivity and driving economic growth, a lot of the benefit falls in that space as well by keeping people, living longer, feeling better, staying out of the hospital. They can become productive. They can contribute to society. So the value, I guess, in a way, depends on the lens and the time horizon that you apply. And then I think the importance is that we try to get out of the short-term kind of cost management focus in terms of instead looking at what's the long-term value creation. And I think what we are facing as well when it comes to the investments in healthcare more broadly, I mean, if we look at UK and how much we invest in healthcare as percentage of GDP, I think we are equivalent to many other European countries, around 11% or so. Actually, I think, if you look at the total amount invested in NHS, is, similar to the entire economy of Portugal. So clearly there's a lot of money in there. What we see as a concern is that the investment in medicines over time has come down, and today is only 9% of that total budget, whereas for comparable countries like Germany, France, and Spain, it's between 14 to 17. And I think that sort of disproportional squeeze on medicines is not helping, because at the same time we're also having one of the sickest population among the G7 countries. So I think there's a resource allocation dilemma, and to your point, NICE is a great custodian of taxpayer money sort of value, but it's very much focused on the innovations that you just mentioned. And I think there's a lot of interventions and investments going into the NHS that doesn't undergo the same scrutiny. And I think there's definitely opportunity to free up investments in areas where they're less productive into innovation to drive a longer-term value creation.
Thank you. I'm going to open it up to questions from the audience. I'm going to take a few at a time. So if you've got a question, can you please put your hand up? Wait till the microphone to come to you. Might be a long wait.
Nice quiet audience, yeah.
Okay, yeah, we'll come to this gentleman at the front. And if you could say your name and where you're from, please.
Yeah. Is that working on the microphone? Yeah,
Yes.
I think it is. Hi, just a specific question actually on your last point. My name's Ron Egblay. I've worked in the NHS for many years. That benchmarking that you mentioned in terms of the use of medicines in the NHS, is that benchmarking by expenditure or by volume of product use? Because it might be the case that we're using the same number of products and we're just paying less than other European countries.
It's by expenditure in terms of how much of the budget proportionally we spend on medicines versus total healthcare. I think if you look at the number of medicines available to the NHS, and I'm sure we will have somewhat similar but also somewhat different views on that. If you look right now at the most recent medicines approved by regulatory agencies across Europe, UK is having disproportionately less access to those compared to other countries. If you go to Germany, 9 out of 10 of those medicines are available without restrictions. If you go to the UK, if you look at only those that's fully available without restrictions, it's just north of 1/3, which is also an important element to take into consideration in terms of why we're spending less, because less medicines are available in the UK as well.
I do need to come back on that.
I know.
Yes. We both know this data set really well. So basically, just to explain the data set looks at all 37 European countries. We all pore over it every year when it comes out. Roughly, the UK is 6th out of 37 in availability of new medicine. So that puts us top quartile. So you say, well, how can what Johan's saying be correct? There's another cut on it, which is to say, to what extent are the medicines available to the entire licensed population? So now what often happens with a license is that the license is broader than the clinical trial, right? And because we're quite strict with our evidence requirements in NICE, we look at what the clinical trial that drives the uptake, and that's what drives taxpayer value. We don't think that's a bad thing. So whilst Johan's saying, oh, it's 1/3, we actually say we're 6th in Europe, which makes us top quartile. So it just shows you what is it? Statistics, damn lies and statistics, or
yes.
whatever. Yeah.
I'm going to take some questions online. Matthew, this one to you first. So on the question of uptake and adoption of innovations, they've said uptake may be lower in areas which are less research active. Sites which participate in trials may be quicker at uptake because they're familiar with innovations. Do we track this in any way?
So, to my knowledge, not. And I think this is where it goes back to different bits of government linking up together in terms of measurement frameworks. So, off the top of my head, I do not believe within the league tables that have been published, there's a strong component around life sciences growth, R&D, and so on and so forth. Within the medium-term planning framework, there is a clear aim for clinical trials to start within 150, but it's not necessarily within 150 days, sorry. But that's not necessarily linking up these different lenses of what, and this is why I love healthcare, it's inherently complex, but how you get these different lenses so that same strategic commissioner is aware of, I've got this inequalities within my population, but I've also got this target of doing clinical trials within 150 days. How do I get my team together to view from both those lenses? So I feel like we have to use certain levers which we have to make the incentives for leaders to recognize those dual and complex roles which they have to play.
Do you want to come in on that question?
I mean, the only thing I'd say is the data that I have seen, and I've never seen a study on exactly what the person asked, but there is quite good data on more research active sites have better patient experience and better clinical outcomes in general, not just for the people that are on the clinical trials. So I think that's a pretty good argument. I mean, also, obviously, and you may want to comment on this, commercial clinical studies are an important income generation source for the NHS. So, it's good all round, good patient experience, good clinical outcome, good income, good for industry. So,
yeah. No, I mean, I would concur with that view, especially initially once a drug gets approved and NICE approved ultimately, that we see a more rapid uptake where there's already clinical experience. I think that's natural human behavior, but over time the expectation will then be to see that, you know, where there are concentration of patients with unmet need, that's also where the usage of the drug would increase. And I think here, arguably, we still see too much of variation across the country, and I think variation that cannot be explained in a meaningful way, and also just shows the shared sort of problem and opportunity we have in really making sure that we actually reach underserved communities, that we tackle health inequality in a very intentional way, because I think that's the opportunity we have in terms of really driving population health outcomes in a better way.
I actually wanted to pick up on that question more broadly. Obviously, particularly for digital tools, there's kind of great promise and great store being put in them by the 10-year health plan. Obviously, the risk is that there are kind of a large number of people, some of whom are very intensive users of the NHS, who are not as digitally literate as others. So how do you think the government as a whole and kind of individual parts of the NHS can ensure that greater use of those tools doesn't mean that some people are excluded and find it harder to access that care? I might come to you first.
Yeah, so this is really interesting because every time we look at a digital tool, we ask the manufacturer and the NHS and others, do you have any data on digital exclusion and kind of inequalities that are being perpetuated through the rollout of this? That's the data set that almost always the answer is no. So I think we've got, from our perspective, we have a number of hypotheses where we say we think this may be difficult for people with a learning disability to use. We think this may be difficult with such and such, but actually the data is really poor at the moment. And so if there's anybody in the audience who is bringing a technology to market, I think that would be the main plea, is really look at variability of uptake in your kind of target population.
Yeah, so I struggle with the dichotomy in this kind of question, the way it's raised, because in Northwest London, we've done a lot of work in terms of health equity, and we have a specific digital inclusion working group. And I think it's the NHS's responsibility, just like any other healthcare system, to be responsive to its population's need. So I believe that the NHS will always need to have some form of face-to-face provision for certain care pathways in line with what the different demographic needs are. The reason why I don't like the dichotomy is because I think creating digital-first pathways enables, for those who do want a more transactional relationship with their healthcare system, can create efficiencies and headspace to provide more time to those who need a face-to-face pathway. So I really do think the challenge here is the double running cost, but how do we stand up the digital pathways that enable more time for people to have a more deeper human connection when there's lots of the population that will be happy getting a drug on their phone and picking up at a pharmacy without ever seeing a kind of clinician in the same way.
So I'll just ask a follow-up question on that, on whether we know enough about the extent to which those kind of digital tools, thinking about like kind of online triage, etc., those types of tools are actually productivity improvers. Because, so for example, we have just published a performance tracker, and it includes a kind of detailed analysis of general practice. And you talk to everyone about the kind of appointment data, and no one really seems to know whether a digital appointment, what that actually means. Is that an email? Is that kind of multiple contact points? Is that the back and forth? And so I don't know, do any of you have any insights on the extent to which we know whether it is actually saving time? Because I agree that case, for those who want to access digitally, it's more convenient, that's compelling, but do we know whether that's actually the case at the moment?
So I can only ask, because we don't have a productivity tool, so I can answer for digital diagnostics and therapeutics. In general, we are struggling to see data that absolutely proves resource savings. And that's for two reasons. One is a slightly technical reason, is because often the studies aren't against standard of care, so it's kind of tough to say, well, what resource was used in standard care, what resource is used in this. But the more common reason is that people just look at the points cost. So I'll give you an example of an AI in chest X-ray, for example. I'm not picking on this, but AI reading a chest X-ray, you go, oh, well, it's 1 second, and a clinician takes 3 minutes. So that must be that full difference between 1 second and 3 minutes must be the saving. But actually, that's not the whole pathway cost, because then what proportion of false positives go onto a CAT scan from the AI? Well, that may be a lot. What proportion are checked again by a radiologist? Well, that may be a lot. So we're quite tough, as you've gathered, with figuring out the full cost effectiveness. Is we look at the whole pathway of implementing it, training people, getting it into your system, et cetera, and when you look at the whole pathway, a lot of these initial claims start to break down a little bit.
So do you want to come back on that?
No, and I want to build on this. Who is looking at this, right? Because as you say, the NHS is a huge amount of spend, and I think that we get into sometimes differential scrutiny about where things are happening. So there is a lot of activity which sits outside of NICE's regulated space, right? And therefore, who is, I suppose, assessing actually this type of digital pathway is actually going to generate efficiencies, and you can reallocate your workforce to somewhere else. And I do think that is a genuine gap in terms of proportionate rigor that needs to have to address some of these problems. The only kind of counterish point is we have seen private sector companies invest in lots of these digital pathways, and if anyone speaks to anyone on their bank, it is a sort of very digitalized mode of things. So I'd argue and this is why I use the word proportionate, there is clearly enough evidence that some of these digital changes will create efficiencies, but within a taxpayer-funded system, I do think we need to have people who are looking at this as well.
I mean, whose job do you think that should be? I mean, I don't want to expand NICE's remit while we sit right here, but is that something NICE should be taking on? Are there other existing organisations?
So I think the Health Innovation Networks play a role in helping to support and evaluate the tests of those particular things. It is not a national regulatory role, but in terms of providing proportionate, responsive research and evidence to our commissioners to say, actually, we think that this is something which you should be investing in. For example, there's been a massive ambient scribe technology clinical trial which has looked at the evidence around this. So that type of responsive research I think is very important to help make decisions in a time frame that is commensurate with how fast the world is moving.
Yeah, and do you want to come in?
Yeah, but I'm looking just to provide another perspective. I think we also need to recognize that, when it comes to adoption of technology, there's also a human behavioral or cultural lens that needs to be factored in as well. And I think there's of course a sort of polarity in between the speed of technology and what it enables, and then also what we are capable in terms of implementing and make use of in complex systems. And I think there's still a tendency to dismiss things that doesn't deliver immediate value because it requires a lot of change management. And it's for the NHS system, but working in a large enterprise, we go through the same thing day over and over. So I think it's the direction or where we're going is inevitable. We're going to get there, but I think we just need to be able to sort of hold that ambiguity as we move through the implementation phase and we start to understand where and how it creates most value, and look at what are some of the quick wins that will get people on board and feel like actually this is meaningful, rather than say, I need to solve the biggest challenge we're having right away, because then it's easy to become a little bit,
I'm going to open up questions from the audience again, see if anyone's creative juices have been flowing and has any questions. Yes, over here.
Hi, I'm Daniel Measer on behalf of Feedback Medical. For a bit of context that leads into that conversation, we supply a clinician-to-clinician collaboration and communication platform. So it's very much back-end, it's not patient-facing right now. With the shift in the 10-year plan, I think there's a risk of a knee-jerk reaction to simply put the current working model on a digital platform, put it on a computer. And as has just been said, not every working model can easily be digitized or put onto a computer for it to be made more efficient by doing so. So how do we use technology to actually redesign how the NHS operates so that it operates more efficiently, rather than trying to shoehorn in the technologies where you might not have an immediate use case?
So that's a really good question. How do we avoid just creating a digital version of an old system design rather than using the opportunity of the shift to digital to create something different? Yeah, I might come to you first on that one.
Yeah, so I think this is a really good point. I think so there's, the ambition and the delivery of the 10-year plan, but I think there's also the ongoing NHS reform that provides an opportunity to take a step back and think at what is the right operating model, literally from the center. What is it how do we contract, how do we measure impact, etc. And I think really to create a fundamental shift in all of this, that's where you need to start. You're right from the center in terms of how do we actually orchestrate, deliver, and measure the impact of what we're trying to achieve. And I hope that that's an opportunity that we will lean into in terms of thinking fundamentally, how would we change the operating model?
Sam?
Yeah, I mean, it's the million-dollar question, right? So I'd imagine there's a top-down and a bottom-up approach. So if I think about what we're doing at NICE, we're trying to digitize our processes. And there's two things we've learned. One is your data's all over the place and it needs to be standardized. And two is there's not a standard process that everybody's absolutely following. And even if they were, that process is not the ideal process that you want to digitize. So that is very hard to mandate from the top, right? If I were a company like yours, what I would be doing is thinking about what are the big processes that I would be applied to and work with little bottom-up hospitals where whoever GP practices to say, okay, across that pathway, what are the most impactful use cases? Because we see a lot of digitization on things that are not that resource intensive. I mean, you're not going to have that big impact. Mm-hmm. Then I would collect the data on that, and then that's the kind of thing that can be scaled. But at the moment, we don't have the data, we don't have the processes, we don't have the high impact use cases. And so it's quite a hard thing then to control centrally because you don't actually know what's going to benefit people.
Yeah.
And I think this is where the health innovation networks, I think, have a very, very clear role, where we exist to help support innovators like yourselves and the system to ensure that there is value within those. And in terms of going back to what we were discussing earlier, it is through these pathway review processes that you start to realize, hey, why are we doing this like this? It's a broken system, and therefore actually some of the value gains aren't necessarily from the product itself, but from reviewing a pathway which we've done for 20 years and no one's bothered to look at again. So I really do think that the health innovation networks, in terms of being that translation mechanism, have an important role.
I'm going to take another question from online. So someone's asked, it strikes me that digital innovation happens in a siloed way, e.g. at departmental level, when actually one needs to consider pathways, patient journeys across primary, secondary, tertiary care. So how can we think about it in a way that isn't siloed? I might come to you first.
So I think we attempt to think about within pathways. So at the Health Innovation Networks, we always say pathway, not product. And that is a fundamental kind of belief that we have. I think for me, at a government level, I think there's something about how we think beyond the NHS silos. So we know we have a massive issue in terms of people being unwell and unable to go to work. And therefore, how are we working with DWP and health? And there's some really great initiatives from Department of Health and Social Care and DWP, which is the Work Well program. And I think more of those, actually, we've got a problem which is manifesting in this department. And the solution may be in health, because that's where we have lots of contact points with the public. And how we better create those kind of cross-departmental programs, I think, is what I'd be looking for to kind of build off that question.
Yeah, so I mean, the good news is I think we're better at looking at pathways than we used to be a couple of years ago. And pretty much nothing that we look at is all in one organisation. So I'll give you a couple of examples. Well, think about the artificial pancreas we talked about. It's paid for between a combination of primary and secondary care, and it reduces the costs in secondary care. Right, so now you've got an organisation that has paid for something and has reduced their income, because if you reduce costs, you kind of reduce income. Or we've got something which is a device that picks up kind of how your defibrillator is doing, it reduces the number of admissions to hospital. Again, will reduce your income. So actually, people are quite good at looking at the pathway and going, oh yeah, this would work for the pathway and we're happy to do it. Where it really falls down is how the money flow works, is we don't really have payment mechanisms that help do that. And we've tried so many things. We've tried best practice tariffs, we've tried, what was it, Year of Care, my personal favorite. So I'd love to see in the future that we have a smorgasbord of different options for how you pay for something along the pathway that commissioners can use for different types of issues.
Can I add one?
Yeah.
Well, completely agree with everything said. I think the also other thing is a payment mechanism to move from sickness to prevention, because that may also have this kind of different organisational bit, but we're also forecasting into the year. And there's a small sentence in the medium-term planning framework saying that this work is being done, and I really welcome that, because we just currently, so we do a lot of work on detection of cardiovascular disease. There's no currency that says you've detected someone earlier, this is an income for you.
Yeah. Great point.
Obviously, that's one of the hopes of integrated health organisations, that they will kind of help that flow a little bit more. But obviously, the downside risk of that is that if it's acute trusts who are in charge of those, that even more funding might flow to those acute trusts rather than prevent. I mean, what do you think government needs to do to avoid that happening?
Crikey, I'm probably the least expert person on IHOs, so...
I might come to you.
So I think it's important to say that the integrated health organisations are not going to be organisations as currently think it is. It's a contract and agreement within localities based on who is the best integrator within that base, and I think that flexibility by government is good, because in some places it will be acute, in some places it will be community providers. So I think that allowing a system to make a decision about what the best integrator is important. I do think what your question flies out is this challenge in implementation, which is how, when we have such crippling estate problems and so on and so forth, and these leaders are still CEOs for their organisations, how they are enabled and given the freedom to not fix the leaking roof, but also maintain some money and budget towards the prevention activities and so on.
John, do you want to comment on that?
Yeah, I think for me, of course, I think we have a tendency to overemphasize or fall in love with structures and processes and pathways, where I think actually more longer term the solution would be around really understanding and organizing yourselves around the problem that you want to solve, and then incentivizing the outcome you want to see. Because I think if that is what becomes the guiding point for everyone, then you can start to think about, okay, what does then the enabling organization look like? And I take it that's a big ask of a very complex system like the NHS to think of. But I think ultimately for me, pathways is a great example of moving into that direction. But for me, as long as we become caught up in how do we structurally organize ourselves versus what is it that we're trying to solve for, then I think we're going to continue to talk about different ways of trying to integrate silos, but we're never going to get to the core of the issue.
I've got another question here online that says, we seem to speak a lot about making the NHS want to adopt innovation and the role of push factors from the centre. Are there ways to strengthen pull factors from the Frontline itself? Matthew, do you want to come first and then?
Yes, because I could see you were thinking. I'll get started and hand over to you. So yes, we asked this question actually working with the Health Innovation Networks about a year and a half ago, where we said we always look at the things that didn't get adopted. Why don't we look at the things that did? So like the positive deviants, and what did they have in common? And the questioner is exactly right on that there were a couple of central things that needed to be in place. So some of the things we've talked about, there needed to be a clear national policy with funding mechanisms that followed it, clear clinical leadership, but actually some of the local things that were really important were local clinical leadership does not have to be a doctor, really importantly. So if you look at HeartFlow, which was a kind of cardiac AI, the cardiac imaging technicians were the key ones because they all know each other and they were super connected with each other. So there's something about a clinician who's very connected into the network. There was something about the fact that a lot of clinicians don't believe the data, or they believe their patient cohort is different, etc. So that there's an ability to be able to audit your practice when you implement something, and also support getting the business case written and getting it through all your different layers of governance in your organisation. And then there was an element of kind of communication and storytelling. So often we speak in medicine, and I've been the same here, talking very dry stats, 22,000 patients, blah, 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 but actually you need to hear the patient story as well as just the kind of the raw, this is what the RCT said. But there were 10 factors, I haven't done them justice, but those are some of the things that were in place in all of the innovations that spread really well.
Yeah, I'm trying to come in then, or to you, Matthew.
Yeah, and maybe I think for me it's you know, you need to understand what are the motives, the drivers and the barriers and the belief system of the people on the front line that's actually going to deliver the innovation. I think we have a long-standing partnership with NHS on a sort of national level in England around delivery of, you know, innovation in the lipid space,
yeah,
for lipid management. And I think we spent the first 3 years trying to understand what gets in the way of a GP surgery to deliver this innovation. And it comes very much down to their everyday reality of, you know, whether or not what we're offering them aligns to their priorities. Of course, it's about doing what's best for the patient and getting patients to target and avoiding cardiovascular diseases. But then for a GP surgery, they're worried about workforce, workload, income. So if you're not able to introduce your innovation in a way that fits or enables or actually improves either of those levers, you're going to have a very difficult challenge. But if you do understand it and you can work with them, you can go where the energy is and you can deliver great outcomes for patients, for society, and for the individual frontline user of the innovation as well.
I paused because I think the most important, well, I think there's a really interesting case study with the weight loss drugs, where we have a patient-led pull factor in a way that I've never observed before. We have people taking out payday loans to try and get things. We've got people going to the black market, literally injecting themselves with drugs that they do not know. And I think there's something about how is the system genuinely responding to that citizen demand? And not all of these are patients and so on. So I think there's something for me about how we are able to truly kind of get to a place where we're able to be representative of the demand for certain medications that is there. Because for this one, with completely justifiable reasons at this moment, there's a disconnect between the population demand, the policy intent, and where we are at the moment.
We've talked quite a lot today about how the NHS healthcare is part of a sort of a wider system, and that kind of spending there will see the benefits accrue elsewhere. And obviously, that's kind of one of the reasons why you need sort of effective coordination from government. And obviously, the 10-year health plan is meant to be part of that. The health mission was meant to be part of that, and also there's meant to be coordination from number 10. I wonder the extent to which you think these issues are being coordinated well, that there is a kind of strategic approach across government, and that we're kind of moving beyond just the kind of the NHS being a very inward organisation. Matthew, I might come to you first on that.
So I think we are at the start of this. So this week, and there's been lots of work led up to this, but this week we have London Life Sciences Week, which I think is a good example, and it was chaired by Dame Caroline Clark, who's the London Regional Director, and within that room you had representatives from the NHS and the multiplicity of types of stakeholders in the NHS, life sciences, health tech, family offices, and so on and so forth. And that sort of coordinated effort about making London a global city to invest in, but also the UK. So Manchester is doing some excellent work in terms of how it has taken its devolution and really created a front door for England. And I'm a Londoner who supports Manchester United, so there's a bit of a tension there. But I really do think about, we are in a global race, and I think this is an old stat, but we represent 3% of multi-pharmaceutical industry's business. So we have to really capitalise on what our assets are if we are going to create a more productive economy.
Yeah, so I'd say it's a lot better than I've ever seen it before, but it's quite a complicated thing, because if you think about the small thing we were talking about with pathways moving between primary care and secondary care, now you're taking that up to the whole of government and saying, actually, could you theoretically move money from DWP, because they're no longer having to see somebody in a job centre, into the health service because you've given somebody bariatric surgery or whatever. So I think it's a hugely complicated thing to do, but two reasons why I feel more confident than I ever have on this. One is that on the medicines pricing work that we're both working on, the conversation is exactly at that level. And that would be the first time I've seen in 10 years, right? Where all the different parts of government are thinking, what does having medicines in this country mean from us, from a trade point of view, from an investment point of view, from a health gain point of view, and therefore how do we value them? So I think that is really positive, and it may not come out that way in the press, but it is actually very positive, the kind of conversations that we are having. The second is that for the first time, NHS England has done some work collecting DWP data sets with NHS England data sets. And so the first time we actually know what conditions and what interventions are associated with increasing tax receipts and reduction in unemployment claims. And spoiler alert, it is bariatric surgery and cognitive behavioural therapy. So I think that's early days. You can completely see that data set expanding and expanding. I think that's really exciting. I've not seen that before in this country.
Yeah, I think you're right. And I think, to build on your point in terms of, innovation and inward investments into, life sciences from a UK lens, we're in a global race. That's very clear. And I think our competitiveness will come down to our ability to demonstrate whether or not we have a system that's willing to adopt innovation. And for me, that is at the center of why this becomes a shared problem and a shared opportunity across departments in government. That of course we need to solve for the NHS 10-year plan and the ambition. At the same time, we have a very bold ambition stated regarding life science as a growth sector for the country, where we say we want to be a leading economy in Europe by 2030 and short only of US and China in 2035. And I think what we're trying to solve in the sort of medicines pricing and access element of that shows how that becomes a convening power, because it's very obvious today that UK is missing out on investments that are going to other markets that are faster at adopting innovation. And that's the most important lens that we as a global company takes when we think about investments into market economies. And I think that's why I believe we have a unique moment in time right now to come together and solve for the bigger picture rather than just the individual priority.
I agree.
Thank you. On that note, I'm going to bring this event to an end. As I mentioned at the start, this is the second in a three-part series of events looking at implementation of the 10-year health plan. And the next event is looking at structures. And that is, sorry.
Even though you've said we should focus on outcomes.
I know, and Johan's actually going to be on that panel.
What irony.
Alongside Samantha Jones, Permanent Secretary of DHSC, and Penny Dash, Chair of NHS England. So if you want to sign up to that, it's already live on our website, so do register now. In the meantime, thank you very much to all three of our fantastic speakers, to Novartis for supporting this event, and to everyone who's watched live or is catching up later. Thank you very much.